Let's enjoy chest radiographs with Dr. Y. Session 4, Pleural Effusion. Before starting the Session 4 of Pleural Effusion, let's review the Session number 3. Just slowly and closely look at the picture here. What do we see? We see the right side visceral pleura and fissure here, minor horizontal fissure, visceral pleura, and oblique major fissure, and visceral pleura of right lower lobe. Just remember the last session and look at closely this film again. Name of the sign and patient position silver plate. Yes, position is spine. The patient is looking in bad condition. Intubation tube here, central line in the superior vena cava, and some catheter here, BP shunt. Okay, the circles on the right side is relatively deeper than left side, and we see the visceral pleura and black area of pneumothorax. That is AP position and pneumothorax, deep circles sign. Great. Case number 3. Innumerable small lung cysts are scattered on the right side lung and pneumothorax lung on the left side. In pneumothorax is here and here. We see also the deep circle sign. And deep circle sign makes the left side diaphragm more brilliantly. It is according to the Mach band effect. Session number 4, Pleural Effusion. Definition is a buildup of fluid between the layers of tissue that line the lungs and chest cavity. Somewhat long and boring. I would say simply fluid in the pleural space. We remember the definition of pneumothorax, gas in the pleural space. This image shows left side pleural effusion. This gentleman is all we know as Sir Isaac Newton. He found that apple is falling from the tree to the ground. That is gravity. So air is on the top, lung is in the middle, and heavier fluid is in the lower portion, and in the beneath there is Earth's globe. Gravity works in pleural effusion too, as in pneumothorax. Air versus fluid, lighter one versus heavier one, up with air, down with fluid. That explains the findings of pleural effusion and pneumothorax on the chest radiographs. This is a frontal chest radiograph and a lateral chest radiograph with upright position. Left pleural effusion. Let's remember the right side first. This is normal finding. What is abnormal on the left side is the finding of the patient. So let's go. We don't find the left diaphragm. And we see the homogeneous density of a very high density, white density here on the left side. And the beak-like meniscus sign showing in upward direction, also in the medial side, obliterating the left paraspinal stripe, and also with aorta line. And we see only one diaphragm on the left lateral film. This one is probably on the right diaphragm. Where is the left diaphragm? It is embedded in the pleural fluid on the left side. Same as PA film, because this is also the tangential image of pleural fluid. Homogeneous white density, obliterating left lower lobe, and beak-like appearing on the posterior CP angle. We call it CP angle obliteration of posterior portion, and also the anterior portion. This right side image is a left decubitus film, and the red arrows are directing the gravity direction here. Okay, the dense white area is on the lateral side, representing heavier material on the lateral side, a lighter material of air in the medial side. Actually, these two films are all using gravity as tangential image, differentiating the interface between the air and heavier fluid here, air and heavier fluid here. So I can tell you that this frontal image is good enough to diagnose pleural effusion in this case. 5 days later, the patient image was looking just normal. Look at this frontal PA film. Left diaphragm is visible, left lower lung vascular rate is preserved, and CP angle also looking very good. In lateral film too, two diaphragms are visible, but in the decubitus view, we see the small amount of free pleural fluid shifting. We used to say that decubitus film is better than lateral and PA film when the pleural effusion is small. We already know these two films. At session 1, this normal PA of young man, healthy man, and session 2, this is normal healthy young woman's lateral film. What will be the right side pleural effusion? Just imagine and draw the picture here. Let's draw. Okay, like this. Okay, like this, an obliteration of this diaphragm. This diaphragm will not appear here, and this diaphragm, left side one, will be visible only with attachment with the left side heart. Let's make a diagnosis here. Right upper lobe here, because this is minor fissure, so we can say this is right upper lobe. Right upper lobe consolidation representing pneumonia. And right side pleural effusion here. White, dense, homogeneous area with CPA blunting, medial side blunting, clear line. So, pneumonia with ipsilateral pleural effusion. We also have small pleural effusion on the left side because his heart is not so good. An old man admitted to our hospital with a high fever, cough, chill, and sputum. His radiograph shows white area here in lower long john with homogeneity, and unclear diaphragmatic margin representing pleural fluid, and a bronchogram with consolidation in right lower lobe representing pneumonia. In 2 days, it is going bad to worse. Pleural effusion grows, pneumonic consolidation grows to the middle lobe, and then in 2 more days, it went to worst. So we introduce a pigtail catheter here to drain the pus. The CT at the second chest radiograph shows middle lobe consolidation, lower lobe consolidation, and pleural effusion down and up. This is pneumonia with pneumonic effusion. It can be sometimes fatal and grows very fast. Let's see another patient of a pneumonic effusion. This patient shows right upper lobe pneumonia, including middle lobe pneumonia, with homogeneous, round, well-defined border medially representing pleural lesion, not lung lesion, with homogeneity. So we can define as pneumonia with pneumonic effusion or empyema. In this contrast-enhanced axial CT image shows the pneumonia and localized empyema here. So pneumonia with pneumonic effusion, and why this line is so clear, sharp, because this one, not from lung, but from outside of lung, pleural or extrapleural lesion. We are now familiar with the left side pleural effusion, right? Yes. We see the pleural effusion on the left side, on the PA film, on the lateral film. But the inner surface as medial surface is somewhat irregular or ragged appearance. This might represent this is not a transudate but exudate. Without adequate treatment of empyema or loculated effusion, the patient can go like this. At first, left side thorax is smaller than the right side, normal side thorax, and intercostal space is also narrower than the right side. This means this is a chronic process with shrunken left side thorax. And we see the left lower lung zone, these thick inner surface of pleural calcification and lateral calcification with inside calcifications. On a lateral film, we also see this same linear outer side of calcification and calcification everywhere. Let's compare side by side with coronal chest CT. This is a visceral pleural calcification and parietal pleural calcification and calcification of inside. Same as this one? Yes, most probably from tuberculosis, and this is a chronic empyema. These two films are same patient, same day images of supine AP view and frontal erect PA view. Both are representing bilateral pleural effusion. As we see, there is a high density homogeneous white area right side and left side, meniscus signs, costophrenic, angle obliteration, and no sign of diaphragm here. And we also see the obliteration of left paraspinal stripe and even the aorta line, all representing the pleural effusion. This is AP supine view, so gravity direction is anterior to posterior, so that is not like these erect images. Pleural effusions are not here, but scattered spread diffusely on the posterior side, more clear on the left diaphragmatic side than the erect view. His CT image shows bilateral pleural effusion and obliteration of paraspinal stripe here because fluid is here and meniscus sign here. Paraspinal line obliteration is more frequently observed than CP angle obliteration because, as we see, medial side collects more fluid than the lateral side. What is the position of this image? Yes, it is AP supine film. And what's wrong with the film images? Let's presume the left side is normal. Yes, diffuse haziness, homogeneous haziness on the right side means something here, and no air bronchogram represents lung is okay, and accentuation of minor fissure suggests pleural effusion there. Although chest radiograph and CT is a different machine, but the image direction of X-ray gravity effect is same with these two films. Pleural effusions here when the gravity affects here. So what we see here is actually this one. So supine image pleural effusion is now getting familiar and familiar. Let's get more familiar with the supine pleural effusion. Erect versus supine. Tangential view, unfolded view. Gravity direction. These two films are same patient, same day. This one is AP supine view, looking normal, looking okay. But actually she has both sides pleural effusion, but looking normal and the supine view. The name subpulmonic effusion means sub, below, pulmonic, lower lobe, below the lung pleural effusion, because it is misunderstandable. Yes, but we are familiar now with this bilateral subpulmonary effusion. This is another patient's several days later film. At first, she was normal. We are familiar with these normal images and bilateral subpulmonary effusion. It is misunderstandable as normal chest radiograph. Let's be careful with subpulmonary effusion. If you see these two films, look closely and closely and closely. Now I can presume that all of you will understand and diagnose what happened to this patient. Yes, phantom tumor, vanishing tumor, actually not a tumor, just vanishing with position. It is rather likely transstate, not exudate, fissural location of a pleural effusion. Let's go further. These two images are both sides of decubitus films of the same patients. Right decubitus, fluid went to lateral side. This left decubitus, fluid went to medial side. Yes, vanishing, they vanished. It means gravity dependent, they are moving. In reality, they are not usually so well moving. They are usually there constantly. Actually, so this is fissural effusions. They are broader meaning of effusion, and the vanishing tumor is a small group in fissural effusion. If there are huge amount of pleural fluid on one side, it usually pushes mediastinum to the left side, so heart will be more to the left side. But in this patient, the trachea is there, heart is there, not moving, so we call this frozen mediastinum. It represents that right side has not only pleural fluid but also tumor, pleural seeding, pleural mesothelioma. So the malignant tumor cells are fixing the right side pleura and mediastinum. And we can see the multiple hematogenous metastatic nodules on the left side lung. So frozen mediastinum means serious condition of pleural malignancy. Let's summarize transdate and exudate radiologically. But it's not 100% definition, just radiologically more likely possibility. On the left side is transudate, bilateral manifestation. Uni and ipsilateral manifestation. Transparent, pus or bloody, shifting, fixed, systemic underlying disease, local disease, heart and kidney disease, but lung and pleural disease, low Hounsfield unit, high Hounsfield unit. Please look these three films. At first, we imagined and draw the picture of right side pleural effusion. After looking these films and compare what you have imagined, was that match? Concur with your picture? Let's summarize in our mind. What is the position of this image? Yeah, supine AP film. What is the findings of this patient? Yes, bilateral pleural effusion. We see the heart border on the right side and left side. This means heart is in anterior location and fluid is not anterior location. This is about the story of silhouette sign. Let's talk it later. And what do we see now? What kind of image? Yes, erect frontal view. And what is the diagnosis? Airspace consolidation of pneumonia right upper lobe, bilateral pleural effusion, obliteration of paraspinal line. Do you concur with me? This slide is just a quiz for next session. What is this? Small, round, empty ring just beside same-sized, round, full white moon, full moon. Do we still have these to enjoy chest radiographs? Anatomy, imagination, familiarity, curiosity, and just one more thing, enthusiasm. Like, subscribe will be a big support to me. Thank you very much.